Hello, we are Team 36 from Seoul National University Hospital. Our topic is development of an AI model for non-invasive prediction of cardiac output. Cardiac output is used to monitor and optimize systemic oxygen and drug delivery for high-risk surgical patients. Hence, immediate treatment to keep moderate cardiac output levels during surgery may improve patient outcomes. An accurate cardiac output monitoring requires invasive catheters, which may lead to severe complications. Therefore, we tried to develop an AI model that could help clinicians to monitor the cardiac output for general patients without risk of serious complications and improve patients' postoperative outcomes. The cardiac output is the value multiplied by the heart rate and stroke volume. And the stroke volume means the volume of blood pumped from a left ventricle per beat. Our AI model predicts the stroke volume so as not to be affected by the heart rate and be made a prompt prediction. We used VitalDB, an open public physiological signal database, which has collected synchronous vital signs and biosignal data from various medical devices using Vital Recorder program during surgeries. We obtained 765 surgical cases to predict cardiac output using ECG, PPG, and patients' demographic information. Since the tendency of cardiac output value is crucial information, cases with small number of cardiac output changes during surgery was excluded. To build a dataset for AI model training, ECG and PPG waveforms were extracted at 100 Hz. We tried to predict prompt target stroke volume from just before 20-second of input waveforms. Hence, we obtained the 205,962 sample segments from 755 surgical cases. We conducted several pre-processing to make the quality of the data clean. We applied a Butterworth filter to ECG and PPG waveforms to remove high or low frequency noise. Also, we removed any samples that include erroneous data such as not a number value or flatline, or abnormal waveforms in ECG or PPG. We extracted additional features from ECG and PPG to help improve the AI model performance of predicting cardiac output. PR interval, QRS duration, QRS amplitude, street segment were extracted from ECG and first derivative, second derivative were also extracted from PPG. In addition, pulse transit time, an indicator of blood vessel elasticity, was extracted from ECG and PPG. A randomly sampled 20% of cases were used for testing, and the training and testing datasets had completely disjoint set of patients. Patient demographic information was not statistically different between two datasets. Due to the known auto-scaling issues in PPG waveform was normalized in the input segment, and other features were normalized for the entire dataset. The normalized dataset was trained on CNN model based on SE-ResNet, which is motivated by a MIT 2022 paper. As a result, the performance of our AI model were 11.0 milliliters per beat in mean absolute error, and 39.4% in limit of agreements. Through Bland-Altman analysis, it can be confirmed that most predicted values are included within the confidence interval. Also, through four-quadrant plot, most points outside the exclusion zone were located in the first and third quadrants, indicating that target stroke volume and our predicted value relatively agree. In qualitative analysis, we could confirm that our AI model is tracking the target SV well. Note that orange line indicates target stroke volume and green line means predicted stroke volume from our model. Since main purpose of cardiac output monitoring in clinical practice is to tracking the long-term trends of hemodynamic changes, we evaluated our model's performance by applying 5-minute median filter and checked long-term tracking ability. As a result, our model achieved 10.4 milliliters per beat of mean absolute error and 36.6% of limit of agreements, which was better than short-term performance. Also, concordance rate of four-quadrant plot showed the higher, therefore, we could conclude that our non-invasive AI model works well for tracking the cardiac output. There are several limitations in our study. We used arterial pressure-based cardiac output as the gold standard method, which might be a little inaccurate. A practical guideline for clinicians to determine whether the new measurement technique represents a good alternative to the reference standard is limit of agreement under 30%. However, our model has a larger error value than the standard at 36%, which requires more improvements. Our non-invasive model enables clinicians to monitor cardiac output without risk of serious complications. we will use more data and improve the model so that it can be monitored in intensive care units as well as in operating rooms. Thank you for listening.